I've also been doing quite a bit of online work around the world. So last Friday, for example, I was able to provide some support sessions for, I think, 8 countries around the world. It's quite amazing what you can do online. And I suppose that's one of the big differences between Ebola and COVID, is that we're using a lot of online facilities. But thinking about these epidemics and what they are, it brings up the worst and the best of people. And we are seeing the worst things happening, and we're seeing the best of people. So they're very similar in this way. The fear is very similar. With Ebola, one thing I recall is that if you had a temperature, you were a dangerous person. You were at risk. In COVID-19, it's even more scary because a temperature doesn't mean anything necessarily, because you could be asymptomatic. Last week, I was talking to someone, one of my colleagues here, and they developed a temperature of 38 that day. That was, I knew myself how afraid I was, as I have an underlying health condition, so it's pretty bad if I get anything. So going, yes, this is just a random picture. If you can see, I hope you can see these pictures. I have very few pictures of myself, so I thought I should show one picture at least with all my proper signage and markings of WHO, because when you work with WHO and these organizations, your signs, your indicators of where you work becomes really, really important, which is quite different if you're working in the NHS. I don't know about the Irish Health Service, but I've got to say, in Sierra Leone is the most beautiful country in the world. It was not a harsh place to be at all. This was from my hotel room every night. Beautiful scenery. This was Freetown. I went back after Ebola, and it was like nothing had happened. No one was talking about Ebola. And that makes me think, yeah, maybe COVID will be the same. In a year's time, people will be not even thinking about COVID. Generally, epidemics come and they go, and that's really important message that I pass on to people who are feeling very stressed. Yeah, so similarities. It shows, if you're in a poor country like Sierra Leone, it shows you the weaknesses in services. It brings out the worst and the best, as I've said. The other thing I really found in Sierra Leone, and I don't really know with COVID yet, is how it affects children. And I think that it's probably something we need to reflect on in our own work if we're dealing with a lot of COVID now. How are your children dealing with this? When schools are closed, and I think that's the case in Republic of Ireland, children are affected. Sometimes they don't know what's happening. And schools, when you open your schools again, it's when society is beginning again. But there is a lot of problems with children, behavioral problems, and a lot of us because they just hadn't been told properly what was happening. And I think that's a lesson for COVID, just be very honest with children. The other important similarity is that people are resilient. People are not victims. People survive. In global mental health work, we talk about stress and dealing with stress, and certainly Ebola times was full of stress, and COVID, but we overcome it. It's a small number of people who struggle to deal with, who really succumb and are not able to function. So Sierra Leone is, as I said, beautiful country, 6 million people. Life expectancy is 47 years old. It's awful. The first time I went to Sierra Leone was before the war of 2000. And I remember I was going through Sierra Leone to get to Liberia, which at that time was having a dreadful war. And then Sierra Leone had the terrible war. the last time I was in Sierra Leone, I remember just seeing so many people with amputations of their arms because of the war, which was one of the war crimes. So this is kind of where they had this history. Um, Drug problems, yeah, if you go to the psychiatry hospital, most of the, a lot of people are there because of drug problems. Sometimes people ask me about, what was the relationship between Ebola and mental health? Or did people with mental health problems get Ebola more frequently? We expected that. We built an Ebola treatment unit at the psychiatry hospital, but we saw no cases of Ebola in people with mental illness that were attached to the main psychiatry hospital. Traditional healers was the other thing that was quite interesting in Sierra Leone. In a lot of low and middle income countries, traditional healers, they are where you go if you have any mental health problems or physical health problems. But in Sierra Leone, the traditional healers were part of the problem because they spread Ebola. They were doing things like they were touching people, they were using, well, one thing that happens in Sierra Leone that was really scary was that after a funeral, or when someone dies, like let's say someone very religious or something, they used to wash the body and then they'd use that water to kind of bless all the people in the village, and there was huge amounts of death. So dealing with people's beliefs in traditional healers and funerals was so important there. I don't know quite how that reflects with COVID, but I think that people's beliefs about COVID are probably very relevant as well. My job, I took over my job from an anthropologist. So we started off with anthropology and really thinking about how people believe, what people believe about Ebola. And I think that might be a lesson for COVID as well, what people feel about COVID. Now, this is kind of a typical picture of Sierra Leone. It is so poor. You can't imagine how poor it is, grinding poverty. I really don't know how people manage to live day by day. And then they had Ebola. And Ebola made things 100 times worse. Yeah, I won't go into the history of Ebola, but it started in 2014, and my history at Sierra Leone was before that. I was a lead for a mental health project, which is why I think I got invited by WHO to lead on their project there. But one of the big things was the stigma and the myths. The stigma of having Ebola was extraordinary. If you had Ebola or were a survivor, you were a discriminated person. I know what that felt like a bit because when I was in direct contact with someone with Ebola, when our driver died, I was on my own where I was staying. People were clearly distancing themselves from me, probably quite rightly, but I really felt how strong and how horrible stigma feels. All sorts of myths come up, like, for example, that if you take someone's temperature, people thought you get Ebola from that. I can't see that quite so much with corona, but I am absolutely sure that in low and middle income countries, there will be all sorts of myths. There's been Ebola outbreaks since then in DRC. There was Ebola outbreak in Guinea, and people trying to help were killed trying to help because they were seen as being too connected with Ebola. Children of frontline workers with Ebola were discriminated against. People lost their accommodation. And now we see with COVID, if you are in quarantine, you have to be separate. And I've talked to people in quarantine, and it's very, very difficult. It's a very isolating experience. Um, so, so with all these infections, what always strikes me is that although like Ebola is absolutely lethal and so viscerally scary, people bleed from their eyes, it's awful. But Corona as well causes such a lot of fear because you don't know who's carrying it and it's so infectious. Yet, in both, hand washing properly is such a savior. Keeping your social distance is such a savior. So easy things, easy public health messages can actually help this so much. Um, so I'll go to the Psychiatry Hospital, Kissy Hospital. This is the one national asylum hospital in Freetown. And honestly, they'll say themselves, the conditions were just so awful. Most patients were chained up, and they were really embarrassed about it because they had no resources, very little medication. The first time I went that time to Kissy Hospital, one of the staff members had just died. And we were doing some talk about World Mental Health Day, and really it was, people were just in such pain. One of their own had just died. It was really, really awful. So it was like nice the next year when my colleagues were able to go back, and we had such a message of hope, which I think hope will be the same for COVID, because you always have to have hope. But even with that, no cases of Ebola happened there. The other thing that's really important is human rights. And this was before Ebola, currently, and after that. Now I'm faced in my work in the UK at putting people in seclusion, partially due to their COVID status. We're restricting people's liberty. We're not chaining them, but it's because of COVID, which raises such a difficult issue. Now, building back better. I think this is probably could apply to Ebola and COVID. This is what we go to when we're looking at helping in a low-income country or wherever. You go respond to an emergency and you try and make things better for the future. So this is what we did with Ebola. We tried to make things sustainably better for the future. And this for COVID as well. How will we make our service better when this is over? How do we learn? What do we do that can be better? I'm learning as I'm going along as well. There's things that I will do different now after this. So yeah, the challenges of Ebola, stigma I can't underestimate. The issues of funerals. A funeral in the time of Ebola was the most dangerous thing in the world. I've seen dead bodies, and that's so scary because that was just like a factory of Ebola. I remember one day outside the main psychiatry hospital, the main general hospital, and there were people sort of hanging around outside because the Ebola treatment unit and waiting area was full up. So it was looking at these people and knowing, yeah, some of you are going to have Ebola. I remember as well, there was someone had discarded some clothing, some trousers and shirt or something on the ground, and I just almost stepped on it. And it was seeing something like that, which could be such a high Ebola risk. Now, when I go into the train, I'm kind of looking at things where there potentially could be coronavirus on the seats of the train or whatever. In Ebola times, a lot of health workers died. We see this in Italy as well, and Spain. We've seen health workers in the UK. I don't know about Republic of Ireland. So at the time of Ebola, my role was as a public mental health specialist. So it was far broader than my role as a psychiatrist. It was really thinking about how you deal with people from their basic needs to how to help people with severe mental health problems get help. It was also looking at supporting primary care services, but it was also about supporting communities and family. In the number of disasters that I've been to in humanitarian settings, what keeps people going is family and religion, I think, is what I see everywhere. And I think this is the same with Corona. You stay strong if you've got family. And for those who are religious, keeping together with their religion, I get a bit alarmed when I see people in a place like Sierra Leone and say, no, I'm no longer religious. I've lost my religion. I hate God. I get a red flag because they're going to be especially vulnerable and they're like suicide risk, etc. Now, Connacht Hospital, this was our daily routine, washing our hands in the chlorinated water reservoir. So the difference between Corona and Ebola is Ebola, the smell of chlorine everywhere. And I think we had to wash our hands for 5 minutes there, if I can recall. So it was much more extensive. But the visceral fear that Ebola would be a death sentence, which is not quite the same for Corona. I haven't shown you the pictures of the main hospital, of the main entrance, because there were dead bodies there all the time. Or there were people around with Ebola. It wasn't really a safe place, or it would be undignified to show pictures of that, I think. PPE, the same here as in Corona and Ebola, the same, except the PPE for Ebola was really very, very uncomfortable, and you couldn't afford to make a mistake ever. Whereas in the PPE that I'm using day to day, I think I'm making mistakes every single day. But thank God I'm still okay. So Ebola, one of the big pieces of work we had to do was about working with survivors of Corona, and I don't think that's the same as Corona survivors. But survivors of Ebola were seen as witches. They would lose their job, they lost their families, as well as having neuropsychiatric complications such as vision. And Corona is interesting because we hear people talking about visual effects of Corona. So it could be that Corona is a far more extensive, multi-system effects on the body. So this was a survivor of Ebola. I always remember what he said. I'll put in the next slide. The worst part of Ebola was, and his family were in the same unit and many of them died, was food being thrown at me. The staff are frightened. They stay away from you. They don't treat you as a person. They don't call you by your name. Now, I thought, yeah, that's Sierra Leone, that's West Africa, that's terrible. We've learned from that. But I've seen it in my own unit happening. I've seen the person with COVID having food just left at the end of their room on the floor for them, and people being depersonalized. So I think, gosh, have we learned? Maybe not. Ebola time, what we were dealing with. Now, it was not about PTSD. Often people in global mental health think that it's about PTSD, and it isn't really. We expect about 15% rate in times of humanitarian crisis. But it's often overdiagnosed. And the problem with that is you give someone a diagnosis that's potentially gives them a sick role behavior. And our psychosocial response was about telling people how to manage their stress, how to get their basic needs met. We did not want to make people doubly handicapped. We really wanted to tell people, yeah, you're doing really well. The other thing we see, and I think this is Corona time as well, is gender-based violence, an increase of domestic violence. We're seeing it already. I've seen it in my ward everywhere. Substance abuse is a big problem. And as I mentioned, stress problems in children, I think, is a really big issue because people don't ask people don't ask, how are your children doing? We do staff support, but are your children okay? So the sort of interventions we did were looking at that pyramid I showed earlier. We're on the 4 different levels of the pyramid. So we were supporting the psychiatry hospital. We're supporting primary care in dealing with mental health issues. We were supporting communities. We would find if there was someone who was respected elder in the village, yeah, we support them. We give them some resources to have meetings. We let the community build up in their strength. We did psychological first aid, which is nothing special or fancy, but it's a way of dealing with people in distress in a dignified, humane, and supportive way. It's contrary to critical incident debriefing, which is something that did have its day, but we now know since the Bosnian War, effectively, that critical incident debriefing can potentially be harmful. We still see it happening, but the main message from psychological first aid is if someone has been through something terrible, don't make people talk about it unless they want to. If they want to, that's great. The other intervention, yeah, building back better, make things better in the future. Then there's mhGAP, which is about, which is our non-specialist manual from WHO in dealing with mental health issues. So these are some of the tools we used in West Africa. I'm going to slip through a few slides because it's probably a little bit time pressured at the moment. Yeah, other messages really get coordination. And this was one of the joys of working in Sierra Leone, to see we really worked hard at coordinating all of our efforts, everyone doing psychosocial work. And this is how I got to know people from Concern, Goal, lots of Irish organizations. This is how we got linked to people providing livelihood, which is so important. You can't have mental health if you don't have your basic needs met, or if you're working. That's so important to people. At the burial teams, having a respectful, dignified funeral is so important. That's something for Corona times as well. I'm so impressed with the ICU nurses I've been supporting. They tell me that they make a big effort to link families into their patients in intensive care unit. They want to make sure that the family aren't excluded. Okay, so other important parts was messaging. And this is something from Ebola. They had kind of quite graphic messaging. Corona as well, graphic messaging. And it's all of our jobs as health workers to keep on with that message to our patients and our staff. I will just, yeah. So this is kind of, well, a lot of what we did in Ebola time was role play, psychological first aid, using role play as a very important tool. And we are doing that now with Corona, with a number of different countries. We had a whole lot of people that we were training in psychological first aid. I probably should say that I can send the links to these tools later if you'd like. It was a joy to do psychological first aid and learn from people and facilitate rather than teach, because it's very difficult for us to tell people what's right in Sierra Leone. And also for health services in Europe as well. We learn from how what they have learned is helpful. We really we invested in people. People were really, really important. So the same in Corona, invest in people, respect people, value them for what they're doing in such terrible times, putting themselves and their families at risk. So this was a picture, I think, when I was leaving Freetown, and it reminded me that I was able to get a plane and leave, whereas people there were stuck. I never expected that one of the next huge world disasters would be on my doorstep. And London has been an epicenter, which thankfully we're getting out of. People ask me how I kept sane, and I'm not sure I always did keep sane, but it was like this: being with other people. That's what kept me being sane. Taking my temperature twice a day kept me sane. I will skip that. And just to emphasize the basic needs, yeah, mistakes we've made in the past. This is learning. Assuming that everyone is traumatized. No, they're not. People have great strengths. Looking at trauma rather than what's stressful in their community at this moment in time. I learned that from every disaster I go to. It's extraordinary. Like, you were in a war zone, and people are worried about organizing their daughter's wedding party. That's always what it's like. It's about people are in Bangladesh for the Rohingya. They were talking about not having enough food or not having proper housing. It wasn't so much talking about what had happened to them before. Not being culturally appropriate, very, very important message, or having parallel services. So setting up like a PTSD clinic, which people love to do, is terrible for global mental health. And the same, I think, for Corona, that people shouldn't be kept separate because they've had Corona. So don't do standalone or trauma counseling. And just to, yeah, in the tools I've mentioned, PFA, mhGAP, avoid using drugs. In Sierra Leone, we hardly used any drugs for people. It was all about stress management. Same for other disasters I've been to. Advocacy. Now, I would have to speak to ministers of health. I would have to speak to senior people in other organizations. I don't have that role in my current role in Corona, but maybe some of you will have that. You have to speak and shout loud for mental health people, for people with mental health and how COVID might affect them. Now, things that aren't our natural job in psychiatry, but in getting recreation sorted, sport, art, culture, religion, that was all part of what we were doing. Very far from what our traditional role in psychiatry is, I suspect. Gender-based violence, this was a very important area for us and is now currently. So I'm just going to go very quickly, because the time is a bit short. Lessons, we formulated a few lessons, and I'll just go through these quickly. Most people are fine, whatever has happened. Only a small number of people will have problems, but you get overall a doubling in the rate of serious mental disorders. So you might have to build up some capacity around that. Healthcare workers are particularly vulnerable, and I won't go through that, but frontline workers are very, very stressed. They need to have some time off. We need to ask, are you okay? Have you got money? Is there anyone sick at home? That sort of pastoral element is so important. Their childcare. The other thing is having adequate equipment to protect themselves. I know myself, I have this chest problem. I've had to really strongly ask for the proper mask to wear when I'm dealing with COVID cases each day. And there is a lot of documentation now that we can use. There was a lot of learning even now on Corona. Yeah, respecting staff, making sure people work in a safe environment, and I'm going to, leadership is so important. That's another important message. Respect and dignity. The pyramid, which I alluded to earlier, is a good way of dealing with things, where you look at basic needs, community supports. And I won't go through that so I can have more time for questions. I think that's probably the last of my slides. And you can share these slides, so you can have these later. And just to mention that we have got, if anyone is interested in global mental health work, we do have our special interest group in the College of Psychiatrists. And something that we have been doing around different parts of the UK, and it'd be wonderful to do it in Ireland, would be to have we have these weekend trainings for people in mhGAP, some of the tools we use in global mental health. As it's my home city, I'd love to do it in Dublin sometime. Thank you. And I haven't checked any questions yet, but I'll just have a look at the, in fact, I can't access the questions, but perhaps you could pass me if there's any questions.
Yes, it may be that people have been sending me questions. I certainly have a couple on my screen.
Oh, okay.
And if anybody else has questions, you can either send them to everyone on the chat if you want everyone to see, but otherwise you can just send them directly to me, and I'm not naming any names of the questioners, so you may feel relieved about your question. Peter, thank you very much from that. It must have been an amazing and a very frightening experience to have lived through that. And just before I go through the questions, and the fact that Ebola, to my knowledge, is as yet, incurable. There's no treatment for it. How do you think Africa has, perceived or taken on board or reacted to this new worldwide coronavirus, given, the fact that Ebola was so deadly? I know, obviously COVID is not, but it's very infective. So both your own reflections on that, because this is the first pandemic that we've lived through in developing countries or developed countries, and kind of how does that trigger memories of your period there?
Well, it's kind of like my sister lives in South Africa, so I hear about how strict their lockdown is, much stricter than the UK, and they're not allowed to have alcohol or tobacco or anything. Very strict. What she tells me is, yeah, that's fine for us, but people in the townships are starving because they've got no food. So it's the cases still in South Africa are I guess they're manageable, but it could explode. What I really fear, and this was our big fear in the time of Ebola as well, that if you got an outbreak in such a densely populated place such as Kinshasa in Democratic Republic of Congo, it could explode. It could absolutely, Lagos, these big cities where it could really spread. What I'm hearing still is that the caseload is still not so high. And I think for a lot of Africa is so rural and there's less issues of social distancing, but overcrowding, who knows what's going to happen, and it will expose weak health structures. And if you're talking about psychiatrists and what our role is, in many countries in Africa, there's like one psychiatrist for the whole country, or a minimal amount of psychiatrists. I do know that through WHO, they are looking at plans for each country and a psychosocial response. So, and a lot of guidance, but yeah, it's a scary place. It could be scary.
Why do you think that the infection rates have not increased, given the fact that they have such a low base, but that in certain of the cities, the population density is so huge that, it's not possible to have any semblance of physical distancing?
I don't know. And with Corona, for example, I know that I have been with patients who have Corona and I haven't had proper PPE. I've had staff members I've worked with Corona and I haven't contracted Corona as far as I know. At the time of Ebola, I remember one of my colleagues was trying to stop an Ebola positive patient running away, and she physically grabbed him, but she didn't get Ebola. So there's so many things about why some people might get these infections and some may not. I think there's a lot of unexplained things, and why these epicenters seem to be drifting from one place to another. The current epicenter is Brazil, but I think people are really fearful of what will happen in Africa. The other place that people are really fearful about is India, and Bangladesh, where I lived last year, is so incredibly crowded. Pakistan is also another place that's really at risk.
And a question here, which links with this, I'm jumping down, but do you think it's to do with not testing, that actually the prevalence is much, much higher?
Oh, that's a good question. Yeah, it could be, but I'm not hearing from people saying that we're having lots of deaths. I'm not hearing. So it could be that there may be some ethnic variations in a susceptibility, but we see in the UK a higher rate of death in people from BAME backgrounds.
Yes.
And I think, like I know, like in Egypt, for example, there's a lot of cases in Egypt, a lot of death, and it's not being recorded. It's not being picked up as COVID cases. Yeah, it's probably a mixture of factors, but I think it's these epidemics, it's like an earthquake. When you have an earthquake, one house can be fine and the next house is destroyed. Sometimes you can't understand these things.
There is a question specifically on BAME group in the UK, and whether have you any idea as to why that is? Is it a question of socio-demographic issues? Is it genetic issues?
I don't think, I think the jury is out on that, and it's probably going to be multifactorial. I think if you're a health worker, you're going to be at increased risk of contracting corona. Health workers are automatically a higher risk group, and a lot of our health workers in the UK are BAME backgrounds.
Okay.
So maybe that's a factor as well. But there's also like issues about BAME background people. It's not, it's a bit universal to say, but some communities are in overcrowded housing, less opportunity for social distancing, and maybe there's nutritional vulnerabilities. There's also issues of drug use, and drug use may make people more have more risk-taking behaviors.
Unfortunately, the most vulnerable are vulnerable to many other things. There's a question here, Peter, which thanks you for the talk. It was interesting. He wondered, the questioner wondered, what particular skills does a medical psychiatrist bring to this experience? And could all that was described have been done by a non-medic?
Okay, interesting question. When I am working around the world, I never really refer to myself as a psychiatrist. I refer to myself as a mental health specialist or a mental health and psychosocial specialist. Because the skills you need are beyond psychiatry. But on the other hand, the skills I've learned in psychosocial skills, I've been able to bring to my own practice in the UK. But I think generally we're trained in psychiatry in quite a narrow way. So when I'm working in humanitarian settings, it's a kind of, you have to have a public health perspective as well. So you might have to look at why things happen, what is the social circumstance, you need to look at the culture, and it can be as much as kind of advising on livelihood for people. It can be advising on something like latrines in refugee camps. And something you don't always think about, but if the latrines are not well lit, or if they're mixed gender, it's a recipe for gender-based violence and all sorts of social issues. And the unit of kind of mental health that we deal with in a lot of these disasters, humanitarian settings, is stress. Stress tends to be pretty endemic. And although mental illness is stigmatized, people sometimes can talk about stress much more easily. I found this in Syria and Iraq. People will accept that we are stressed. So I think a lot of my work has been about stress management, and that could be done by anyone. It could be a psychologist, social worker, whatever. I suppose my skills perhaps would be to know about the medication specifically, and the top tier, which is the people with schizophrenia, severe bipolar, etc. But the joy of this kind of work is that the hierarchies are gone, and we work well with psychologists, social workers. Interestingly, the head of WHO mental health at the moment is a psychologist. And I remember the cheers that went up in WHO Geneva when she got her appointment, and people were saying, first they said, finally a woman who's head of the department, and people cheered. And then when they said, and she's the first non-psychiatrist or non-doctor, then people even cheered even more. So I think it's refreshing to not be tied down to our professional backgrounds.
Well, I think, you know, the reference you made to the WHO psychological first aid support is very much on the importance of anyone being able to offer that PFA. And so there's really, you know, the ability then to identify, as you say, not to pathologize the normal reaction to stress, which for the most part is adaptive, but it's only when that persists for longer or starts to, you start to use maladaptive coping that there is a need for more specialized mental health support. And maybe increasingly then you're going to mental health clinicians, and then the role of the doctor within psychiatry is certainly linked with, you know, the medical aspects, medication aspects.
And it does kind of really broadens your mind when you work with different disciplines, and it kind of helps you have a much broader perspective. When I'm doing trainings, for example, I always love to have a social worker, a psychologist present, so that the doctors have to, we're not, provoked is probably not the right word, but we're kept on our toes, and we have to justify things. And in a lot of places in the world, I have worked in Ireland, so I'm sure Ireland has changed since my days years ago, where the doctor was quite a revered person, and you wouldn't dream of calling your doctor by a first name. And now that's not the case in a lot of global work. We get our hands dirty like everyone else.
Right, right. Peter, you mentioned about the fact that certain countries, you know, kind of start at a very low base rate. And I guess in Ireland, although we are a developed country, unlike the UK, we get 6% of our GDP going to mental health budget. So what advice, a question from a participant, we need to focus more on mental health in Ireland for sure, but have you any advice about advocacy and how we can get a bit of the whatever budget or money is left in the country after COVID?
You got to keep on shouting. You got to keep on shouting for mental health. On the media, the ministers, everything, you got to keep on shouting about mental health. I remember in Sierra Leone, I would go along to every meeting of the country director that was about, it was about sanitation, it was about Ebola units, whatever. And I kept on there. I kept going to that meeting. At the end of my job, I was asked, why do you keep going to that meeting? Because you're mental health. Why would you be going to this meeting where they're talking about infections and infectologists? And I had to say, no, it's my job to have that visibility and presence so that mental health gets into everywhere. And I've got experience in Ireland as well, where I had to advocate for mental health when it wasn't always looked at. I think still areas of development in Ireland and where I live in the UK as well.
I think we're lucky at the moment in that our College of Psychiatry here in Ireland have written to, you know, the government highlighting the importance of mental health and what will be a need to really strengthen that, you know, after the surge of mental health, which we're seeing now at a clinical level. And I guess the other thing just to make our participants aware of is the College of Psychiatry, again, that published the Irish Journal of Psychological Medicine, have devoted a whole issue to COVID and mental health.
Great. And
it's available virtually online, and the hard copy will be coming out, you know, we hope in maybe August.
Oh, I must watch out for that.
So that's really, I suppose, key to advocate, and maybe we need to link more with the media. There is a clinical question here, Peter, in your role as a psychiatrist and the fact that you're involved with the COVID cases as well. Can you mention something about whether there's been any neuropsychiatric complications of COVID?
Now, I've heard people talking about them. I know that in our physical health hospital, I'll use that in inverted commas, they've had a lot of cases of delirium. And I've been consulted about some very strange cases of behavioral problems where people were saying this must be psychiatric, but it was someone who was 52, first episode, but they have corona. So I think it's going to be an interesting question. In Ebola times, we did some specific research on looking at neuropsychiatric complications of Ebola, and we really didn't find that many. There were effects on eyesight, subtle effects. There were subtle effects of neurocognitive function. But with Ebola times, the treatment of Ebola is effectively to induce cerebral edema. So that is going to be damaging in its own right. But what will happen in the longer term for Ebola and corona, it's hard to know. People I know who've had corona have said, yeah, it took quite a while to get over it. And I know people have had cardiac complications as well as lung fibrosis, and whether there's neuropsychiatry, I would imagine, like every infection, one might expect to have some depression afterwards, survivor guilt, and all these kind of psychological issues as well. But on the other hand, if you're looking for a nice research project that lends itself to getting funded, I think that's the one.
Yeah. Well, funding would be great, and it is the big problem in any of the great research ideas that people have. But just continuing with that theme, in terms of the increasing amount of neurological sequelae that are now being reported, and including a lot of, atypical strokes and, being either embolic or vascular,
Yeah.
and the fact of, anosmia being one of the first symptoms.
Yes.
It's strange, really, that I think that we haven't seen more neuropsychiatric presentations. And if you think of the pandas, where there was an autoimmune reaction with, what was meant to be strep, but, I do think it's interesting. I know there are some colleagues online that are also liaison psychiatrists, and please do pop up if you have any in your hospital. But Peter, I do find it interesting we haven't seen more.
It's interesting because you would expect sort of microvascular problems in the brain and etc. But it's still very fresh. It's still, like, I think probably looking at the Wuhan cohort, probably we're looking at those 6 months on and seeing what's happening to those people.
Right. Maybe it's too early for some of that. There's a last question, because we are very close to the end, and thank you very much for your questions. There's a last question on what supports are happening in the UK to support frontline workers. And I guess just to make sure in Ireland that we are, trying to make sure that we're strong in that field.
Well, it's, on the one hand, there's very little, and the other hand, there's so many. But we are seeing that some people, health workers, especially in mental health, have a reluctance to see anyone for professional services. We've kind of worked on things like COVID cafes where people could drop in. We've done our support for intensive care nurses, but it's a small minority. We worked with Ebola time as well. We provided staff support as well. And actually staff support is one of the things I think that is most important at this time, and also asking about people's children as well. So I think it's trying to find something that's most acceptable to people. And it has to be that kind of face-to-face, even if it's online, that it's a human contact, psychological first aid based, and that it's not going on about victimhood and stress or sort of PTSD, that it's talking about your resilience and coping with these things. And it's like very interesting, the sorts of things people say to me. Like one ICU nurse said to me, what we really, really hate is every Thursday evening that people are clapping I don't know if you've had this in Ireland, this is maybe UK. The people clap outside, and some of them were saying, we hate this. And it was really interesting to try and find out what that was about. I think it was a mixture of like, we've let people die because we couldn't save them. And also that it was really hard to go home and leave that. I think the other issue with staff support is that for any of us, we don't know at all what it's like to work in an intensive care unit. It's very hard for us to link with that. Just as for Ebola, I don't think people who hadn't been in that could really appreciate what it was really like. I remember for WHO, we had compulsory psychology session pre-deployment and after deployment. I remember for the post-deployment, I was kind of checking that the psychologist was okay. I was worried about them because I had some kind of like, talking about some of my rough experiences. But I felt okay about it, but I think they kind of struggled.
And very lastly on that, and you mentioned it earlier about the risk of pathologizing normal stress. Do you think the public, you know, are sufficiently aware that that we should not start a lot of community-based supports and give them to kids or, you know, adults or elderly, without an awareness that some of that actually might be harmful?
Yeah, I think not having parallel services, but I think social services and recreation activities will be the way to go, and people having opportunity to connect each other. When it's something that's kind of ruminating about what's happening, it depends on what people bring up, but not to have like very special clinics or special groups or whatever. I think, because I have done a lot of groups, and I think it's about having your tea or coffee ready for people and biscuits, and having people being able to have a chat that's in a confidential space. They don't have to say anything or as much as they want. I think that's what I sense is what a lot of people want. And then for some, they want something a little bit more specialized.
Well, that cup of tea is always very, very important. However, the reality is now it's all virtual. So please, after this talk, do go and have a cup of tea and make sure you look after the basic aspects of, you know, food, sleep, exercise, and leisure activity. And I'm just going to end. I have to pull back up my Word document here. Just going to end by thanking you very much, Peter, for the talk. We will certainly take you up on your offer to come over to Ireland when all is safe, COVID safe. And we would love the opportunity for, I mean, what we have to realize as a community is pandemic preparedness is actually essential now. It's like last year's was, you know, nobody would have thought about it, but I think we absolutely realize that this will not be the last. So thank you for that, Peter. And I also want to say hello to you from your classmate, Professor Mary Cannon, who is on board, and I'm sure she might link in with you later. I'd like to thank the audience and, you know, for being here today, but also for your ongoing commitment to fighting the fight against COVID in whatever capacity you are doing it. We will send you a brief feedback request, and please do let us know whether you've enjoyed today, how you're doing, and most importantly, are there other topics that we can offer? We have our timetable full until September, and please do look at it. Not everything will be of interest, but there may be unusual things we haven't thought about or that you would like to know about, and we will very happily source speakers for those. And as I say, Peter was very generous with his time, given you're so busy, and we know you are. The next talk next Friday is Managing the Mental Health Challenges Faced by Healthcare Workers. Thank you, Paul. And I think that this will be very, very helpful to us all. It's by Professor Neil Greenberg. And I look forward to seeing as many of you on screen again. I hope I don't delay. I'll have to sort myself out better. But looking forward to seeing you then. And Peter, thanks again.
Thank you very much. Thank you all.